Hello and welcome. I am Dr. Anil Joshi. Welcome you to my series that is Learn Radiology Basics from Professor. Now today's topic is Dacryocystography. Dacryocystography or DCG as it is designated is a small procedure done by a radiologist with the help of optometrist or ophthalmologist. This is a small procedure of visualization of lacrimal apparatus. Now, before we start, I would like to disclose acknowledgement and disclaimers. Most of the material which we are using in this series or in these lectures are our own material in our own department and where I have worked. However, we do say that certain illustrations, certain diagrams we have downloaded from net which are available as free of cost and those who are royalty free. Here we go to our lecture. First is introduction. Now it's a radiological procedure as I told you for visualization of lacrimal apparatus. Now how or where the apparatus is situated, how it functions, how it is to be visualized, all we are going to see in this series. Now what is the lacrimal apparatus? It consists of nasolacrimal duct, lacrimal gland, lacrimal apparatus, superior canaliculi, inferior canaliculi, and out of that we are going to visualize superior canaliculi, inferior canaliculi, lacrimal sac and nasolacrimal duct, which drains ultimately lacrimal fluid into the nasal cavity. Now how it is assessed? How it is assessed is by introduction of certain contrast. Now that is the procedure. Now therefore the procedure assesses anatomically stenosis or obstruction in the trach. We are going to see superior as well as inferior canaliculi. We are going to see also a lacrimal sac. So if there are any stenotic or obstructive etiologies causing it will be revealed. Now it assesses patency of the nasolacrimal system, that is to carry tears from the medial aspect of the eye into the nasal cavity, of course which is in excess. This procedure in addition to visualization of the structure can also flush the system so that if there are any small blocks, any debris, that can be cleared. Now let us first see how the anatomically things are. Now anatomy first is of lacrimal gland, because the tears are produced in the lacrimal gland. Lacrimal gland is located at the superior lateral aspect of each orbit. So there are both sides, right and left side, it is situated at the superior lateral aspect. Now it is seen in a diagram here, you can very well appreciate it. Now next is the production of lacrimal comes into the eye, or it spreads over the cornea and it is drained ultimately from lateral aspect to medial aspect. Now here it is picked either by inferior lacrimal, it is picked by the inferior lacrimal duct and superior lacrimal duct, and it is collected into a lacrimal sac. From lacrimal sac it gets drained into the nasolacrimal duct into the nose. The lacrimal fluid drains from the nasolacrimal duct into the nasal cavity via the inferior meatus. So at the inferior meatus in the nose, the ultimate drainage of the lacrimal fluid takes place. Now let us summarize the lacrimal pathway. The lacrimal gland or a tear gland is an exocrine gland. Okay, it is located above the eyeball that we are seeing just now, in the anterior part of the upper outer aspect of each orbit. Now the lacrimal gland secretes lacrimal fluid, that is the tear fluid. It's a watery fluid isotonic to plasma, or it is the secretions coming from the exocrine gland spreads over the eyeball. Now the fluid forms an aqueous portion of the multi-layered tear film that lubricates, protects and provides nutrition to the conjunctiva and cornea. Now lacrimal fluid ultimately drains few series of ducts into the nasal cavity. When produced in excess, lacrimal fluid forms a tear and comes from the eyes. Now further, once it reaches to the lacrimal apparatus. Now lacrimal gland continuously secretes lacrimal fluid into the lateral aspect of the superior conjunctiva via the lacrimal ducts. Now fluid is spread over the entire eyeball. At the medial canthus, now this is more important from our point of view. At the medial canthal region of the eye, the fluid collects into a triangular space called as lacrimal lake. Now the fluid is subsequently drained by capillary action into the lacrimal canaliculi, which are small channels within each eyelid via the lacrimal puncta. So what is important? Lacrimal puncta has to be there, that we can visualize. It has to be patent and normal. It should absorb the fluid and it should pass it to the nasal cavity. The lacrimal punctas are the opening of the lacrimal canaliculi, which are located on the lacrimal papilla at the median end of upper and lower eyelids, that we can easily appreciate. Now further pathway. From the further pathways, just now the fluid has come up to the superior and inferior canaliculi. From the lacrimal canaliculi, lacrimal fluid drains medially into the lacrimal sac. So the fluid has come now up to the lacrimal sac. It's a dilated aspect of the upper nasolacrimal duct. So nasolacrimal duct has got upper dilatation and there the fluid now has come. Now the lacrimal sac lies in the fossa formed by the lateral surface of the lacrimal bone, number 1, and frontal process of the maxilla. Now from the lacrimal sac, lacrimal fluid is carried by the nasolacrimal duct, which opens at the anterior end of inferior nasal meatus. Now the duct traverses a bony canal. It's important. It traverses a bony canal because the bony pathologies, when we are dealing, we have to think of this portion of the apparatus. Now the duct traverses a bony canal, that is nasolacrimal canal, formed by the lacrimal bone, maxilla and the inferior nasal concha. Now all these things are very important when we are going to see the fractures in this area and how they affect the lacrimal passage. The fluid subsequently drains posteriorly through the nasal cavity into the nasopharynx, where it mixes with the mucus and is ultimately swallowed. So a small amount of lacrimal fluid is lost by evaporation or absorption across the conjunctiva, because to feed conjunctiva is also its function. Now what is the indication? What are the indications to perform DCG? Now indication. Epiphora. What is epiphora? That's watering of the eye. If there is excess watering of the eye, which can also occur because of excess production, or it can occur because of the blockage to the drainage. So here we are more concerned with the blockage. So epiphora, that is excess secretions or excess tears. Now lacrimal duct strictures. Again it will manifest as an epiphora, but you suspect it as a lacrimal duct strictures. Now obstruction also nasolacrimal duct. As we have seen, nasolacrimal duct, from where it goes anatomically, which are the lesions adjacent to it, and what are the pathologies which can affect it. Now for the evaluation of congenital and acquired disorders of the lacrimal drainage apparatus, we have to do DCG. Now to demonstrate patency of the lacrimal duct, I feel is the main aim for which we are doing DCG. Now what are the contraindications? Each and every investigation has got these two aspects, indication and contraindication. Now hypersensitivity to contrast, as usual. Then local sepsis at the punctum. We don't know the spread infection, or there may be difficulty technically. So first have inspection of both the puncta. Then pregnancy, of course, it's a contraindication from radiation point of view, but the acute infective process by and large is the more important contraindication. Now what are the equipment? Equipments are very simple. They are usually brought by the optometrist or ophthalmologist, who is required also to help us in this process. Now fluoroscopy can be done. It can be done with the help of fluoroscopy, but as the days are going, or subsequently when we have more and more experience, at present we are doing it without fluoroscopy. Now how we do it, we'll come to it. It can be done without fluoroscopy, but the earlier described technique was with the help of fluoroscopy. Now lacrimal cannula or a blood needle with polythene catheter, that is what is required. or sometimes they have got a metallic needle with a blunt end which acts as a dilator also, and which can put dye also into the apparatus. Now the catheter technique has advantage that the examination can be performed on both sides subsequently, and films can be taken during the injection. But what we are following, we are doing it separately. First we do right side, then we left side. Then disposable syringe, 5 ml. Now what are the contrast media? That is usual Omnipec, which is 300 mg per ml, non-ionic, and it has got extremely less side effects. It is very well tolerated. It doesn't have conjunctival irritations or the irritation after the procedures. So it's excellent dye, which hardly is required in quantity of 2 to 3 ml. So it's extremely good. There are no side reactions and there are no local reactions, what we have found. Now patient's preparation, how patient we need to prepare. In case of children, anesthesia may be required. In our studies, we have done studies right from 2 to 3 years till 70 to 75 years. Usually we have not used any sedative or anesthetist, maybe because we have not got infants to perform these studies. But when you are dealing with an uncooperative child, infants, anesthesia may be required, or sometimes just a sedative suffices. Then collect the relevant previous imaging for the assessment. So all the earlier investigation and relevant investigation has to be asked from the patient. Informed consent is required. That is a part of routine. I feel the procedure, though it has got no risk, it should be a routine to take a consent. So consent, written consent has to be there. But more important than consent, or equally important as the consent, is to give patient proper ideas about the risk involved. Now, of course, identification of the patient, that is correct patient's name, then correct side, correct procedure are required. Now, side is required when you are doing bilaterally, but when you are doing only one side, okay, that is not important. Patient identification and other IDs has to be there. Now let us come to the equipment part. Now equipment to be assembled. So you have to have assembly to connect the syringes to the needles. Now second is a torch or light, any, or sometimes the mobile light works. Then magnification, not necessarily, we are not using it. Normal saline, that is also is not a requirement, but sometimes people use it after the procedure to flush the system. Then sterile 2 ml disposable syringe we use. Then needle shifts, dilators, a sterile lacrimal cannula. Then anesthetic drop, yes, we are using a local anesthetic drop. Then clean cotton, that is sterilized cotton what we give, and the gloves. This is what is required. Not much really instrument or much really expensive things are required here. Now let's get started. When you get started, what is the first thing always we do in radiology is explain the procedure to the patient. Patient needs to be explained the procedure. Why we should explain it? That is because patient cooperates you better if you explain this to the patient. If patient knows the procedure, he knows what is going to be pain factor, he knows when pain is going to be there, patient cooperates and we don't have any problem. So explain the procedure to the patient, tell him that we have used local anesthetic, so there won't be much pain. Then our own precautions, like we wash our hands, wear the lead apron, then put on gloves, position the patient comfortably with the head supported. Now in this, what is most important, head should not move side to side, it has to be steady. Now ensure good lighting with torch or mobile light or overhead lamps, that's routinely available. Then place a towel across the patient's neck to absorb any fluid or drainages. Usually fluid comes as a tears from the both sides, but that is also not significant. Let's continue the procedure. Then what we have to instruct patient he or she has to inform us when a bitter taste is felt in the throat. So patient will complain some bitter taste has come in the throat. Why it is important for us? That it gives us the system is patent. So it is one of the on the table assessment that the nasolacrimal duct is open right from the puncta up to the nasal cavity. Now he or should inform doctor. Now there are different ways. We ask them to raise the hands, or we ask them to, okay, you tell us at the end of procedure. So after the procedure, patient tells that they have failed the beta test. Then while doing the procedure, now we have started the procedure. How we do is, we take a 2 ml syringe. In 2 ml syringe, we take a contrast. The dilution may be there, or there may not be any dilution of the contrast. What is most important here is to drain all the secretions from the lacrimal sac. If lacrimal sac is over distended, if you press it from the puncta, you can get the discharge. If the discharge is coming, you have to completely drain the discharges. Now, puncta is to be supervised. You have to see when lacrimal gland is pressed, the secretions comes of the puncta, and here we start the procedure. There should not be any local infection, as we are told in the beginning. Then another important thing when injecting is, when you are injecting a contrast, usually it is from the inferior, the dye should be coming or is coming from the superior or not, has to be seen. So while injecting, please ensure that it is not coming or coming from the superior canaliculi. Patient is complaining of the sore throat in the throat, sore taste in the throat or not. These are the procedures. Explain to patient as well as you know it before doing the procedure. Now, scalp film is the interesting thing. Usually AP film is routinely advised. But AP film, how much angulation you should give is a tricky question. Now what we do is, we just go for the carvel. The usual method to take a orbit extend is in a prone position, but here we cannot take it. It has to be supine. So another best way where we can see all the margins of the orbit and lacrimal gland portion is, and lacrimal sac portion is a water swallow. That also is a prone position. So here what we prefer is, you take the plane X-ray in calvels or reverse waters and find out where the petrous is. If the petrous is obscuring orbit, then you will have to modify the angulations. You have to go for oblique film. So AP scout film is extremely important to design the angle. Lateral usually we are not using. Oblique, yes, we use when we are in doubt of visualization or when we want to know more details, especially if there are fractures. Now let us start the procedure. Patient is asked to lie in supine position on fluoroscopy table with some centers. In our center, we are stopped using fluoroscopy since last couple of years. The lacrimal sac is massaged, as I told you, to get rid of excess secretions, and the lower eyelid is everted. If you invert the eyelid, you can see the puncta. Now, inspection of puncta and inspection of puncta after pressing the lacrimal gland is the essential portion. Now, the superior or inferior punctum is cleaned under aseptic drops. Anesthetic drops 4%, that is, then it is dilated by using the metal dilator, and the cannula is passed. After the cannula is passed, we collect the syringe and inject slowly. Now two things happen. One thing, dye can come in a superior canaliculi. The point is made, finding is made. Then patient is asked whether she or he gets a beta test. If there is no beta test, if rigor is there from the superior puncta, superior canaliculi, we know there is a block for the system. Now, if to fail cannulate from inferior aspect, what is to be done? Now, if the inferior cannulation fails, you will have to go for a superior. So, cannulation can be done from the superior canaliculi as well as from the inferior canaliculi. If inferior cannulation is not done, if you cannot pass a line, a point of observation is made. Now, a fine cannula is inserted into puncta. Each eye, the eye is kept open or closed, and contrast is injected and films are taken. See, this is the procedure what we have shown here. We have borrowed this from the net, and there is no royalty or any charges expected out of it. So it's a royalty free and a free download from net. But it gives an excellent idea as to how to inject it. Now if you see the syringe position or if you see the dye going, you can know the lacrimal apparatus visualization. Now aftercare and the complications. Each and every procedure has an aftercare. So how you do aftercare? You ask patient first to press the lacrimal gland. So the lacrimal gland is pressed, then lacrimal sac is pressed. First is to increase the secretions, and second is to drain the accumulated dye into the sac. Now after these two things are done, almost we are clear of the dye in the eye. Otherwise we ask patient to wash it with a normal saline or with a tap water. Then we check for the local reactions, any local bleeding, any local trauma, and if it is not there, now it is most important is to ask patient to keep eyes closed for 15 to 20 minutes minimum, because we have put local anesthetic. Patient is not sensitive to dust. He should not go into the open air. He should wear the glasses before going and protect his eye. It is showing again lacrimal gland, then secretion from lacrimal gland, how it comes medially, then superior lacrimal canaliculi, then lacrimal punctum, nasolacrimal duct, and how it ultimately comes into the nasal cavity. Now how you interpret? There are two things. One thing is fallacies. If the patient inform better taste in the throat, is okay. But there are drainage into the throat, but patient doesn't understand how to respond it. Then it is one of a fallacy. But we can make it from the films that the dye is going. Now when we are going to have film reading section, we are going to see it in detail. Then first is the patient better taste appreciation. Then if it is there, if patient is cooperative, fine. And still there can be obstruction under physiological condition, even though patient they have felt better taste. See, there are two things. One thing is under pressure and second is physiological. So under pressure there may be a patency, patient may feel it bitter taste, but at actual there may be a partial block or adhesions. So this is one of a fallacy of the test, that though we are reporting it as the patency, there is not a routine physiological condition. Then if functional obstruction is suspected, persistent euphoria in absence of other explanation after the test, when we are certified it, then further tests are necessary, which are best known to the ophthalmologist. Now this is the feedback which patients also knows, that bitter taste, then regurgitation from superior puncta, and if there is everything is fine, the patient is feeling bitter taste, however still there is excess tears, then we can suspect that though under pressure there is a patency, in normal condition it has got a partial block. Now we are going to a film reading session. What we will do in a film reading session? I will be showing you a film. Okay, I will be showing you a film, and then I will be showing you a template under which you will have to make interpretations. Now I will give you 10 seconds. In 10 seconds you have to make your own interpretation as far as the images are concerned, and after that the answer will come. So hardly any information I have to give you. So all will be evident on the screen. Now radiographic technique which you are using here, one I told you is the AP projection is taken as a scout film. Patient is in supine position. Baki films we are not taking squat film. But I repeated it that different center can have different methods. Then in this, the mid sagittal plane should be perpendicular to imaging plate. So perpendicular imaging plate. The beam angulation is cephalad between 15 to 30. Now who determines this 50 or 30? We do it first with the 15 degrees. Keep patient in the supine. Make the mid sagittal plane perpendicular. Give 15 degrees angulation towards head. And if you find the petrous is disturbing you, if it is coming in the orbit or if it is coming superimposing over the area of interest, then you will have to go for different angles. The oblique and lateral projections are optional. Out of which oblique we have convinced that it is useful. Then what is happening? First film is a perfect what we want. It is a perfect orbit because there is no petrous projection in the both orbits. Now use second. If you see second, it's also an AP, but in that you are seeing a petrous. Now what happens because of petrous is you don't get a clear picture. You get obscure picture. But however, what happens is when we started the procedure, there can be a proper angulation. Patients, and when we are starting injection, the chin movement, the angulation changes. So that can happen even if we do it as a correct plane X-ray. So angulation as per petrous position is the prime important thing. Now we come to here as the film reading session. Here you have to report it as the first is punctum, then the inferior canaliculi, then the superior canaliculi, then the lacrimal sac, then the lacrimal duct, and then the pathologies or etiologies, whenever possible, you can interpret. So 10 seconds now. After 10 seconds, it will change. Now see what has happened is the contrast is tracking parallel to the lacrimal sac. What it indicates a fissure sac. Sac is small and scarred, so there is chronic inflammatory process. Plus, in addition, there is a fissure sac. Here, what is important is a history of instrumentation, history of trauma, or history of other severe infection in this area. Now, nasal spill will be informed by the patients at most of the time, but we can also see on the film. Case 2. Again, I'll give you 10 seconds. At the end of 10 seconds, the answer will appear. You will have to give answer in a way it is told. See now what is happening. Punctum is normal. Yes, in film also, and when you are doing procedure also, then inferior canaliculus is normal, superior canaliculus has not opacified, so that you will have to take as a first point. Then lacrimal sac is scarred, irregular, and the nasolacrimal duct has not opacified. So what does it indicate? It indicates a block at nasolacrimal duct, and the etiology should be chronic inflammatory. Now we come to another case. 10 seconds I am giving you to interpret. See now, punctum is normal, inferior canaliculus is normal, then there is no regurg, then there is no regurg from the superior canaliculus, then sac is elongated, partially scarred, then nasolacrimal duct is normal, so etiology is chronic inflammatory. Now this is what we were discussing. We are reporting here as a patency, but at actuals, we have to go clinically also whether the patency is under the pressure, under the test conditions, or it is a routine. Now case 4. Again in same ways we are interpreting. I am giving you a diagram to go through where the lacrimal apparatus is situated, where the block should be. Now punctum normal, inferior canaliculus normal, superior canaliculus normal, sac is not opacified. Sac is not opacified. Okay, the nasolacrimal duct not opacified. Pathology is blocked at the common canalicular duct. Now fibrosis is sac is another possibility. So block can be because of fibrosis also, or it can be because of the stricture at the junction. Now here what we are seeing is the analysis you have to make as per the template you are given. After 10 seconds it will go to interpretation. Now here punctum is normal, inferior canaliculus is normal, superior canaliculus is not opacified, lacrimal sac has what a puckered appearance. Puckered is where there are strictures. So some portion is dilated and certain portion is irregular and scarred. So this is a puckered appearance which indicate a subtotal stricture, and the nasolacrimal has not appeared, indicating it is a chronic inflammatory etiology from nasal side most probably. Now here you can see 10 seconds are given. Punctum, inferior canaliculus, look at the sac, look at the size of it, look at some projections here and there, and the answer now. The punctum is normal, inferior canalicular normal, there is no regurg, it's a small and partially scarred sac, nasolacrimal duct has not opacified, so etiology has to be chronic inflammatory. Seconds. When you are seeing it, see also the sac. Whether the sac is showing any filling defect are equally important. Though we drain them at the beginning of procedure, if they are still seen, then you will have to go for the interpretation stating time. So there is a punctum normal, inferior canaliculus normal, there is ligage from superior. Then the sac is elongated, distorted, nasolacrimal duct not specified. So pathologies block at the nasolacrimal duct. Etiology is inflammatory. There is no patency, no filling defect, which I have told you is very, very important when you are interpreting. If possible, give pressure to the gland and repeat the procedure. If any mucus comes out, then you will have to repeat it. Now here also it is same. We are showing you the picture. After 10 seconds, you will have to come out with your reply. Now punctum normal, inferior canaliculus normal, superior canaliculus, there is ligage, then lacrimal sac is narrow, scarred, nasolacrimal duct not opacified. Etiology is chronic inflammatory. There is no patency. Now here I have told you not only lacrimal sac, lacrimal duct you have to see, but you will have to see if there are any additional structures. I have given you plain film. The main aim of giving you plain film is to appreciate that something, is it look like a radio opaque wire mesh? Yes. That is finding, you have to make a mention of it, and you will have to ask patient whether he had any fracture in that area of the ethmoid or of lacrimal bone. So that history will help you a lot by knowing what that radio opaque mesh, wire mesh is. Now again, that will give you some etiological hints also. If patient had trauma in the same area, if patient had fracture in the same area, that will give you an important hint. So plain X-ray is important from all this point of view. Made a finding, made a use of template, you have written what was there, or in mind you are sure. Now see how much you are correct. Punctum is normal, inferior canalicular normal, then there is no ligage, small capacity for sac, then the chronic inflammatory etiology is okay, and the pressure, there is patency. Now the patency, as I told you, has got a correlation. It may be there or it may not be there after the procedure. So if you have to check with patient clinically if the tearing or epiphoria persistent or not. Now see here, you have to see for the superior, inferior, as well as you have to see for lacrimal sac, and you have to see for nasolacrimal duct. See? Okay, so punctum is normal, inferior canaliculus is normal, then ligage is there, not filling of the superior canaliculi, the small capacity scarred sac, and nasolacrimal duct is normal. It is chronic inflammatory, and the pressure, the patency is there. Now again, make observation how the sac looks like. Whether you are seeing a superior canaliculi, if you are not seeing, yes, you have to make a mention of it. Then some pathological correlations. What is there is normal punctum, normal canaliculus, no ligage, elongated sac, duct not opacified. Again, there is a block at nasolacrimal duct. Now, inferior canaliculus, the dye is put through the inferior, but you are seeing also superior. Look at the sac, it is narrow, elongated, and the answer is ligage filling of the superior canaliculus. Then nasolacrimal duct is not seen, and elongated and partially scarred lacrimal sac. Look at the shape of the lacrimal sac. Now see the injections given from superior canalicular. When we give superior canalicular injection is when there is technical difficulty in inferior canalicular, we have to go through the superior. Sometimes it works. Now here what we are finding is there is ligage, or it is the injection is superior. Yes, you will have to check it. Now the sac is elongated, partially scarred, and there is no patency. So, very happy now, can do it all correctly, diagnose it perfectly. So that was the basic aim of this study. Now see here, what is happening is, there is a big patency, it is very nicely seen. Sac is seen, then there is not regurg to the superior, there is good spill in the nasal cavity. So we are coming to normal, no regurg, elongated, partially scarred, then chronic inflammatory, and there is a patency. Now here we come to a conclusive remark. We have seen initially anatomy, then we have seen a procedure, we have seen technically how a procedure is done, we have seen the certain modifications from fluoroscopy to overcouch, then from different plane X-rays, Scott film, where we have to go with different angulation to get rid of petrous. Then we have seen how a post-procedural care is taken, what is the care to be taken during the examination, what are the instructions to the patient, and at the end of all these things, when we see a lacrimal apparatus, how to report it, how a puncta looks like, that is through your observation, that will not come on the X-ray. So first you observe the puncta, be sure it is not infected. If it is infected, then you postpone the procedure. Then after the puncta, usually the inferior canaliculi, that is cannulated and a dye is injected, and we are taking a picture. Suppose the dye which is injected from the inferior canaliculus comes out from the superior. Now the conclusion is different. We are getting block proximal to the lacrimal side. Now, if patient is feeling bitter taste or patient is not feeling bitter taste. If patient is feeling bitter taste, that means usually there is a patency. But again, I told you, a patency under test condition and a patency while a routine procedure are totally different activities. We may get patency in the test, but the watering of eye continues. In that condition, we have to think of some other conditions or some other test. Now with this, we are coming to a concluding remark. You have seen the images, you are now expert in reading them, and there is not much difficulty you should face after hearing this lecture. Now, what is the conclusion? Obstruction of the lacrimal duct could be total. Pathology could be unilateral, bilateral. Obstruction could be total, partial. Now coming to next point. The obstruction of this valve predominantly affects women. Now, the certain pathologies are more common in women, and there are certain which are more common in men. So that is a statistical different series reports it differently. Our series, we just keep in mind that this can happen. Then there was no significant difference in obstruction by any group. Now, most of the studies what they are reporting is the obstruction were not drastically different at different age. So the age do not suggest what should be the or how much it should be the obstruction. Then other finding includes sinusitis, osteomas, bone fractures, fistulas, diverticulum, and lacrimal stones. So these are some rare conditions. We have seen most of the pathologies are inflammatory or they can be traumatic. So I am very thankful for giving me time. Time is most important, and you have given me time. In my honest effort, I have done my best to teach you what I have learned. It may not be a totally correct study. It may not be a totally correct technique. A modification in each and every technique has to be done by your own experiences and with your own data which you are collecting. You may find certain lacunae, you may find certain drawbacks which you will have to correct yourself. So the best solution is be a part of this process. Keep on doing more and procedures. Whenever you are finding certain problems, get it analyzed as to what should be the solution of it. and I'm sure with that you can give your best results and you can do your best to give your patient the best results. I am Dr. Anil Joshi, lots of being with me again. We are going to have lot of study sessions and we are going to have lot of enjoyable sessions.